Hello, my name is Alexandre Pereira and I'm a vascular surgeon from southern Brazil, and this is the endovascular repair of a suprarenal aortic aneurysm using an off-the-shelf multi-branch stent graft. This is the edited version of a recorded live case. We were dealing with a 6 centimeter suprarenal aneurysm. We had a 20 to 21 millimeter lumen close to the celiac artery. We also have a significant compression of the proximal part of the celiac artery due to an ARCUATE ligament compression. Close to the SMA, the lumen went to around 23-24 millimeters, so a little wider but not good enough. And we had a little more room close to the renals, around 30 millimeters. The patient also had a 25 millimeter right common iliac artery aneurysm, but there's a small neck just before the bifurcation, so no need for an IBD here. We just used a regular extension. We had the right external artery with 6.6 and the left with 6.9, so borderline, but also good enough. We took out the first stent, so we had a little less thoracic aortic coverage. We took it out with a cautery and then released the first two triggers just a little bit so we can release the first stent. So the gold one is the constraining wire and the black one is the proximal fixation trigger. We go along and take it out and just do a little pushing and pulling, pretty straightforward, and resheath the graft like so. We usually do a right axillary percutaneous access. This is echo guided. We place two sutures there. We progress a 12 range 45 centimeter flexor sheath to the thoracic aorta and do a bilateral percutaneous femoral access. We also place two sutures at 10 and 2 hours in both femoral vessels. These are the markers. We can see the anterior markers, 3 dots in the upper part and 3 dots in the lower part, and the branches for the celiac artery, SMA, and both renals. We have 3 dots in the proximal part of each branch and 2 dots in the distal part of each branch. So after positioning, we open the graft with the last of the 3 dots in the distal part just above the higher renal, but this is just a general guideline. We are opening this graft in a stage fashion because we don't have a lot of room inside the aorta. So we are opening the celiac artery and the SMA branches first. We usually catheterize first the celiac artery and then the SMA, and put a stent first in the SMA and then the celiac artery, but we did in reverse in this case because we have a failed first celiac artery catheterization, and we thought we could take a little more time in this, so we went on with the SMA catheterization first. So the SMA, we usually go to the main trunk of the SMA, so we have a little less chance of a perforation. Now we catheterize the celiac artery. This is probably the left gastric artery. We put the sheath in, we do imaging, and we orient the guide wire in the main trunk and then in the hepatic artery of the patient. So celiac artery catheterization, we are doing imaging so we can have more precise stent deployment first a balloon expandable covered stent. As we said, we had an arcuate ligament compression, so we reinforced with a second stent. We can see the neck there. There is a significant compression. We've seen in our previous experience that this is often a problem on follow-up, the compression of the arcuate ligament, so we now usually reinforce in these cases. The SMA stent was pretty straightforward, just positioning of a covered stent, and then we are doing imaging without the guide wire, just with an inflated balloon through the balloon to see any bad angulations. Opening the renal branches, we can see they are not opening fully because there's not a lot of room there. Catheterization of the left renal artery. We first secure the left renal artery, place a stiffer guide wire there, an amplatz wire with a short tip. Then we catheterize the right renal artery and secure it to an advanced sheath inside the right renal artery. And after that, we fully open the graft. We take out the constraining wire. Now we have the graft fully open and deployed. We usually push the graft at this time below the hypogastric artery, so we have some pelvic perfusion. So we went with the right renal artery stenting. We can see there's a neck formation there. There's a sharp aortorenal angle. So we decided again to reinforce with a second stent so we don't have any problems there too. Control imaging is fine. So we went to the left renal artery. There is an early bifurcation, 1.1 centimeters just after the origin. So we place a balloon expandable stent just before this early bifurcation, and then we stand with an uncovered 19-ounce stent in the main branch of the left renal artery, so we have a longer fixation point distally. So now we have deployment of the non-covered 19-ounce stent. Like so. Another imaging through the balloon. You can see good flow, some spasm in the lower pole of the kidney. This is control imaging from the visceral vessels. We went on to use a bifurcated graft. We open the left limb. We do imaging from the right to see the right common iliac artery aneurysm and the hypogastric artery. We also deploy an extension there. We use a compliant balloon on all connections so it can have better wall apposition. Control images from the visceral vessels that we did before, and then from the bifurcated component. Now we had to deal with the percutaneous axillary axis, so we had a wire through and through. We telescope a 7 French 90 centimeter introducer through the 12 French. So we telescope the 7 French, we pull back the 12. We place a buddy wire in case we had to put a stent. We tie the sutures, and we had a small extravasation. In the control imaging, we treated with manual compression, no need for stent there. The procedure lasted 186 minutes. We used 130 ml of contrast, and the patient stayed 24 hours on the ICU, had mild plaquetopenia and a small hematoma in the right axillary axis, and was discharged home on the 4th post-op. Thank you for your attention.